Dr. Barber, thank you for the invitation. It's so wonderful to see so many familiar faces in the audience. It's just it's a joy to be here. Talk about something that I love. Tell you a tiny bit about myself. I'm an Australian, grandson of a Baptist preacher, so I probably don't need the microphone. It's all for the benefit of the, the videographer. People often ask me, why did you go into radiation oncology? I found a fascinating field of medicine. It's the best field of medicine. It's highly technical. It's a lot of lasers, $4 million machines. But the patients are scared, and they need a lot of emotional support. And if you have the ability to explain complex things to people who are scared, you have a gift and an ability that does not exist within every doctor. And so I felt like I was on the earth to minister to people in that space. And the rest of life can get quite complex. But my favorite time is during those hours or hour and a half, or the other day I had 2 attorneys, both of them medical malpractice attorneys. That was a 2-hour and 15-minute visit, and I never rushed it. But the point is, you have the time to spend with people. You see a dermatologist, they have to see 10 or 15 new people a day just to keep the doors open. I need to see 1. And that's the kind of time that I like and that my partners like. One thing I tell almost every patient, this is a bizarre field of medicine. We treat an invisible disease with invisible beams that you cannot see, feel, taste, smell, touch. And then we define success as nothing happening. So the critic could say, the skeptic could say, you're just waving a magic wand. You're not doing anything important at all. And that's where the MPH part of my training comes in, is that we have done randomized clinical trials over the last 40, 50 years, comparing, say, 1,000 women treated without radiation to 1,000 women alike in every capacity except for not receiving radiation. And you can demonstrate that the recurrence rate is halved, 1/3 of what it would be if you just left the person alone. And so what that tells you is that there are, in a subset of patients, and we cannot identify who they are. I wish we could, but we cannot. In a subset of patients, there are cancer cells that are left alive despite the best efforts of our colleagues in breast surgery and plastic surgery. And if left alone, those cancer cells will continue to run their program that Dr. Barber explained of growth and division, and we will eventually be able to feel it or see it on an imaging test, and we would call that a recurrence. Most of the time, that's a salvageable problem, but about 1/3 of the time, it is not. And that's a tough situation to be in, and so that's how radiation helps. Radiation has been effective at treating cancer for over 100 years, back to the days of radium and the discovery of X-rays. Radiation oncologists are physicians who are trained in the use of therapeutic X-rays in the help of patients, most of whom have cancer, but not all. And about 2/3 of cancer patients are going to see a radiation oncologist for a portion of their care at some point in time in the disease course. How does radiation work? In simplistic terms, we are generating X-rays. X-rays are energetic. These are intentionally energetic. It's similar in nature to a mammogram, but a tiny speck of calcium can stop the mammogram's X-ray. So that's not something that would be useful for treating breast cancer. We turn the machine up so that it's producing more and more energetic X-rays that pass all the way through the patient, through the calcium, through the bone, skin, and soft tissue, delivering dose as it goes. Dose is a hard concept to explain to the layperson. We're really measuring ionization events. And ionization events can be measured by an ion chamber in a block of water. We have careful calibrations that are done by the physicist to assure that that's occurring, and we know how many ionization events we're generating inside that patient. The ionization events damage the DNA, and the DNA, in simple terms, is what allows the cancer cell to make a copy of itself. If you damage the genetic material that allows the cell to make a copy of itself, it becomes sterile, and it will die, and it will be replaced with scar tissue, or it would be phagocytized by specialized cells in the body that clean up dead cells. And so what we're doing when we're delivering radiation, we're delivering dose to the tissues, and the dose kills rapidly dividing cells preferentially. And so we actually use one of the key features of cancer against itself. When you think about the breast after a lumpectomy, we have a population of normal cells that is not very rapidly dividing, and we have a population of cancer cells that is rapidly dividing. And a given dose of daily radiation is going to eliminate the cancer cells with much greater frequency than harming the normal tissues. And so at the end of the disease course, what you hope is that you have normal, viable, healthy tissues, and that there are no viable cancer cells left behind. That's the end goal. We can probably kind of skip this slide. First patient was treated in 1896, so we're beyond the 100th anniversary. In the early 1950s, kind of looks like space age. And then this picture is downloaded from our manufacturer's brochure earlier today. That's a Varian TrueBeam, and we have one of these devices at the hospital and 2 linear accelerators of similar capability over at Piedmont West. Radiation is used in my life in this context in 2 different ways, one of which I spent the last 5 minutes talking about. The other is if we have someone who's had a recurrence, or God forbid, they present with back pain or leg pain that's a result of breast cancer that spread before we even knew it was there. In other words, de novo presentation of metastatic breast cancer. I am often called in to help. You could have breast cancer that's growing in a vertebral body and starting to push on the spinal cord, causing weakness in the legs or the arms, bowel or bladder incontinence, that sort of thing. You could have breast cancer that involves the brain and requires specialized treatment, which the radiation oncologist has a lot of experience with. If a bone is hurting, that often responds very nicely to even just a single treatment of radiation delivered in the outpatient setting. So those are the 2 main kind of instances where I'm asked to help people in this setting. I would be remiss if I didn't mention the fact that there's a large team that helps me do what I do. The radiation oncologist is on the front lines. Many patients ask me, so you're going to be back there supervising my treatment, aren't you? And the short answer to that is no. We are supervising it remotely by way of imaging review, but the actual treatment is done by the 4th member of the team there, the radiation therapist. So these are special technologists who have training in operating and delivering radiation treatments to patients under my and my partner's direction. There are a lot of people in the back that make sure that the machine is producing radiation like we expect it to. And there are some New York Times stories that you can read about when that process does not go well. But suffice it to say is that I put a lot of faith that when I write a prescription for radiation, that what I'm prescribing is actually going to be delivered to the patient. And so we have a whole suite of people, the medical physicist and the dosimetrist, who are involved in programming the computer specific to each patient to make sure that we're safely delivering the radiation. And we have our own specialized nurses who are like our frontline people and understand kind of what side effects to expect and coach patients through. There's always a nurse in the clinic when the machine is on. We plan the radiation with a simulation procedure, and I usually describe this like you're visiting a tailor or a seamstress, and they're going to build you an evening gown. On the first visit, you're going to decide whether you like the tailor, okay? Are you going to let them build a gown for you? And if the answer to that is yes, the next visit you would come back and they would put tape measures all over you. So they're really trying to measure your body. And we have a much more efficient way of doing that, which is to run you through a CT scanner in about a minute. And that gives us an accurate replica of what you look like on the inside and the outside. So we can tell where your body starts and stops and how is the radiation beam going to interact with that volume so that we can calculate the dose. So the next visit after that would be to come and try on the dress, and then some final alterations, you're ready to start. So we start with a simulation, which is a CT scan. Some simple marks would be put on your skin just to help us know where the breast starts and stops. For instance, if someone's had a mastectomy, it's often hard to tell where the bottom of the breast was. But if you look outside of the CT scanner, you can see that crease. The crease is still there. And so you know where to put the bottom border of the radiation field, as an example. There are two basic types of radiation that are external, external beam radiation therapy. The one that's most commonly used for patients with breast cancer is something called 3D conformal radiation therapy, because there's less scattered dose. And the beautiful thing about the breast is that it's essentially on the outside of the body. And so unlike many other deeper structures like the prostate or parts of the central part of the chest in the case of lung cancer, there's really nothing that's in the way of the breast. The breast is on the outside of the body. And so the radiation techniques, although they're modern, can be relatively simple. There's a specialized type of radiation therapy called intensity modulated radiation therapy that we have access to, and I'm skilled in that procedure should the need arise. As an example, I had a young patient who had had a lot of cardiac surgery as a child, as an infant, and came to me with bilateral breast cancer with reconstructions. And so the breasts were very close to one another, and it was really very difficult without intensity modulated radiation therapy to treat the skin envelope of the breast, the chest wall underneath, the internal mammary lymph nodes, without resorting to some sophisticated radiation techniques. But that's basically what I want to show. This is just an example of intensity modulated radiation therapy. I include this just so that you can kind of see the machine in operation. The patient is lying on a table, the machine is moving around, delivering radiotherapy, and then in the top left corner you can see some lead leaves that are moving in and out of the beam to shape it, much like a photographer would allow light to fall on or be blocked from different portions during an old school darkroom technique. Okay? Side effects of radiation therapy. Fortunately, this is a disease site that has relatively few side effects in the grand scheme of things. When we're treating deep-seated pelvic malignancies, that has a lot more side effects than when we're treating something that's on the outside of the body. But in general terms, and briefly, you can have some fatigue or tiredness, what I call extra cafe latte sort of tiredness, not sacked out on the couch, but just a little more fatigue. Exercise during therapy helps, so I encourage that. That's the main one that you would experience systemically in your whole body. The rest of the side effects are really confined to the area that we're treating. So if we're only treating the breast, then the radiation field is going to be where the side effects occur. And so you could have some redness of the skin, some darkening of the skin, like a sunburn, suntan. You can have some limited blistering. And I have, in the last several years, been prescribing a mid-potency steroid called mometasone because it was proven in a clinical trial to be better than many other skin creams that people were using. And I've seen that people who are religious with that will not develop what we call moist desquamation, or what you would call a second-degree burn or blistering. Sometimes that does happen in small patches, and we can arrange the treatment beam in a different way. We can institute the final treatments, which are aimed at where the tumor was removed from, a little bit early to help the skin through. But it's a collaborative effort with the patient and the nurse and skin care to get them through. You can have some chest wall pain or discomfort. There can be some shooting pains as the nerves cut from surgery try to regrow to where they were. The radiation can cause some scar tissue, and as the nerve goes through that area, it can cause kind of twinges of pain. Those are generally short-lived and almost always will go away by the time 9 months to a year has gone by after the end of radiation. There are some long-term side effects of radiation which we are concerned about. Dr. Barber mentioned a few of them. We worry about the lymphedema risk. It typically doubles whatever innate lymphedema risk you have. And so if you have had an axillary lymph node dissection and all of the lymph nodes are removed, your lymphedema risk may go up into the 40% range. If you've had just one sentinel lymph node removed, most of us would feel like your lymphedema risk is certainly less than 5%, probably closer to 2%, and radiation might increase that a little, but it's not something that we often see. A quick plug for for Gwen and also for Shayna, in the sense that obesity combined with radiation and extensive surgery is a real risk factor for the development of lymphedema. So the more active you are and the healthier your body is, the less likely that is to be a life-limiting event. The heart is on the left-hand side of the body. And we know from clinical trials done in Denmark that if you compare a large number of women, say 300,000 women, and you break them up into women who have received radiation for breast cancer, comparing left-sided treatment to right-sided treatment with older radiation techniques, there is a mild but meaningful and real difference in the rates of heart disease in women who had left-sided breast cancer treatment. And so what we do is we have a special computer that can watch you breathe. When you take in a deep breath, your heart moves down and to the right. The lungs expand and the heart moves down and to the right. And we have a special video CT scanner that can catch you in that position. So we put a little box on your belly. As the lungs inflate, the box moves up. An infrared camera watches it. And we track so that we only kind of measure you for the dress, if you will, when you're taking in a deep breath. And so in that way, we're able to see where the heart is, and we're able to move it so that it's not in the radiation field. And we feel that reduces the risk of developing heart disease back to the reference level, which would be if you had right-sided disease. So those are some of the tricks. There is the possibility of we all like to avoid radiation. The type of radiation that we deliver is not very good at causing cancer. It's very good at curing cancer. It's not very good at causing it. But there is probably about a 1 in 10,000 risk that we are conscious of in each patient's lifetime that some other type of tumor related to the radiation would develop in the field. It's not always cancer. Sometimes it's just a growth. Sometimes it's benign. But that is something that we watch for. So I typically follow my patients for 5 years with decreasing intervals. The medical oncologist is often following them for 10 years. There are rare people who have a recurrence much later in life, after 10 years. Fortunately, they are the exception. I'm going to say one more thing. There has been an amazing amount of interest recently in trying to increase the efficiency with which we deliver radiation therapy. 5 years ago, as recently as 2 months ago, at some facilities within Piedmont, patients would routinely be recommended to receive a 6.5-week course of radiation after a lumpectomy. And that's fine. It's totally acceptable. But we have good data from my home country, Australia, and the UK, and in Canada, and what all those places have in common is the government is buying these $4 million machines. They aren't privately owned for the most part. And so there are waiting lists. And one of the ways you can deal with a waiting list is that you can increase the throughput on the machine. And one of the ways that you can do that is you can shorten the overall treatment course. And so for many patients, and the indications keep growing, a 4-week course of radiation can be just as effective with less side effects in both the short term and the long term. And that is being far more commonly recommended. So you might hear that called the Canadian regimen or a hypofractionated regimen. But the concept is that you're turning the machine up a little bit each day and you're delivering more effective radiation each day, so you don't need to have as many treatments to achieve the same outcome. So I think that's probably it for until we kind of get to some specifics at the end. I want to allow time.
you.